confident that the value lies within. Problem is, if it turns out that you only have, 5 or 6 patients who didn't have the disease that allows you to say what specificity is, then it can range anywhere across the ROC space. Your confidence interval is very wide. So what that means is that your value of sensitivity, so very carefully specified, can lie anywhere along the axis of specificity. So you basically don't know what you got.
Specificity, or the sensitivity, you have to know the specificity. You have to know how good it is at detecting normal patients, because there's a trade-off. There's always a trade-off. So that gets us in the argument of, and here's a typical example. I'm not going to go through this because I don't want to embarrass anyone, but it's endemic in our literature. I actually haven't found a single endodontic paper where any of this stuff was even understood. There may be some that I'm not aware of, but it's just endemic in our research. And most of this research is just, it's completely worthless. Okay. So, measures of diagnostic accuracy are not fixed indications of a test performance. I hope I've made that clear. Some are very sensitive to disease prevalence, like if you're just testing on patients that come into an endodontic clinic because they have pain. Furthermore, measures of diagnostic accuracy are extremely sensitive to the design of the study, and I think Steve covered that really well this morning. The sampling that's used is really, really significant, and it has to be specified according to the STARD statement. Okay, so here we go. How can it be that the prevalence of a disease can affect the predictive power of an imaging test, if the sensitivity and specificity? I think if you can understand why the prevalence makes a difference, you can make a breakthrough. If you can't understand why prevalence would make a difference, then a lot of this stuff is hard to understand. And prevalence is really the prior probability. So we're going to calculate the way to do this is to actually go through the calculations. We're going to calculate the probability of having syphilis after having given a VDRL test with a known sensitivity and specificity to 2 groups of people, prostitutes and Catholic high school students. So the test is the same. It's the same test. The only difference is the prevalence in these 2 groups. And let's see how that affects the posterior probability, okay? So an 18-year-old woman comes into your clinic afraid that she may have syphilis. The sensitivity of the test is 90. The specificity is 85. A VDRL is performed and the test is positive. What are the chances that the patient has syphilis? And this is something that Steve covered earlier too. You can't answer the question because you need to know the prevalence in the group that you're testing it in. You can't answer this question just by knowing the specificity and sensitivity. You need to know the prevalence. Okay. The patient is an ex-prostitute and IV drug user. The prevalence of syphilis in this profile is 90%. Let's do it. Let's just figure it out, okay? We have 1,000 women. We know the sensitivity is 90%, the specificity is 85%, and the prevalence is 90%. Let's just look at the left side of the graph first. This is the infected side. This is the non-infected side. So you have 1,000, let's say you have 1,000 women. The sensitivity is 90%. The test detects 90% of the people who have disease. So you have 900 people who have the disease. Of the people who have the disease, the prevalence is 90%. Of the people who have the disease, the sensitivity is 90%. So it detects 90% of the 900 who have the disease. So you had 1,000 people, you know 900 have the disease because the prevalence is 90%. So you end up with the number of people that test positive is 810 people. If the sensitivity is 90%, then 10% it doesn't detect. So these 90 who have the disease, but they test negative, okay? Stay with me here. Don't have your eyes glaze over. This is pretty easy to figure out, really. Let's go over on the non-infected side. 1,000 people are tested. 10% of them don't have the disease because the prevalence was 90%. Remember, 90% of the people have the disease, so 10% of the people don't. So of the 1,000 people, 100 actually do not have the disease. Of those 100, 85% are testing normal because that's the specificity of the disease, the ability of the test to detect normal people. And 15% actually test positive. They don't have the disease, but they test positive. So now you have to figure out what is the chance, what is the probability of this patient having tested positive for the disease of having syphilis. And it's very easy to calculate. It's the number who test positive over all of the ones who test positive, whether they have the disease or not. 810 over 810 plus 15. The chance of this IV drug user and prostitute having syphilis is 98%. Let's talk about the girl in the Catholic school. The prevalence of syphilis with this profile of patients is only 4%. So same thing here. 4% prevalence. So you take 1,000 patients, the prevalence is 4%. Of those 1,000 patients, only 40 actually have the disease. Since the sensitivity is 90%, 90% of those 40 have the disease. So 36%, 36 people of the 1,000 actually have the disease and test positive for it. 4 have the disease but test negative. Now let's look at the ones that are not infected. The prevalence is 4%, so that means 96% of the people don't have the disease. So you have 960 people that don't have the disease. Specificity is 85%. So 85% of those 960 don't test negative. You get 816, and the balance test positive. So of this person, of the schoolgirl, what is the chance that she actually has syphilis? Well, it's the number who test positive over the sum of the ones who test positive, whether they have the disease or not. 36 plus 36 plus 14. Her chance of having syphilis, same test, same sensitivity, same specificity, different prevalence, is only 20%. So you have the same identical test, and the only thing that changed is the prevalence, and the amount of risk that is there. Look at the dramatic difference in the risk. So when you start thinking about cone beams, start thinking about this. What is the prevalence of disease in the patients that I am looking at? And when you read papers that specify the diagnostic accuracy, look at the prevalence of the population of people that they're looking at. Because the higher the prevalence is, the better the tool is going to look. Yes? Second example, since people mentioned mammography. Your next door's neighbor wife just had a mammogram. You happen to know that the sensitivity of the mammogram is 80% and the specificity is 90%. Her last test came back positive. They know you're a doctor, so they ask you, what are the chances that she actually has cancer? Anybody have an idea of what this might be? Your neighbor, she's 50 years old, she had a positive mammogram. What is the chance that she actually has cancer? Anyone here besides John know what the answer is? You can't answer that, remember? You need to know more than the sensitivity and specificity. You need to know the prevalence to know what the probability, to know what the risk is. So let's find out, you find out that the prevalence of breast cancer in her age group is 1%. So 10 out of every 1,000 women in her age group actually have cancer. Now you can answer the question. Let's do it. You have 1,000 women, 1% in her age group actually have cancer. So there's 10 out of 1,000 that actually have cancer. The sensitivity of the test is 80%. So 80% of those 10 test positive, 2 test negative. On the no disease side, the prevalence is 1%. That means 99% don't have cancer. Right? They don't have cancer. The specificity is 90%. It detects 90% of these 99 who test negative and don't have cancer. The balance test positive. So what is the chance that in her age group with this prevalence that she actually has breast cancer after a positive test? It's simply this number divided by the sum of these two numbers, 8 plus 8 plus 89. The chance that she actually has cancer is 7.4%. And Steve, are you still here? Did Steve go? Okay. He knows the numbers on these. When physicians are asked, and even statisticians have trouble with this, and all this is it's a problem in conditional probability. It requires, you just solved it using Bayes' theorem, believe it or not. You used Bayes' theorem to solve this. So if the prevalence of disease is high, for example, patients presenting to an endodontic clinic for treatment, then the diagnostic accuracy of an imaging test is going to be really overstated. And a lot of this starred statement involves issues where you're specifying how your sample was taken, what is the prevalence of disease in those samples, because without that, you can't say anything about how diagnostically accurate the test is. Okay. And you've seen this. And this is why these screening exams are so bad, okay? You're going to have so many false positives with these. So many false positives. Because the prevalence is low. Prevalence is very low. So when an endodontist says, you know, I take a cone beam on every patient, okay? Well, okay, but there's danger there. What's the danger? The danger is that you're going to diagnose and you're going to provide treatment that isn't really required because you're using it as a screening test. That's different than if you're using it as something to look at specifically. And now you see all throughout the medical community, physicians are dialing back on mammography, esophageal screening, prostate screening. Why? Because these screening tests are really dangerous, and it hasn't been shown that I'm aware of that many of them actually end up prolonging life by detecting cancers early. Okay, I won't go over that. So these are problems in conditional probability, which is what is the probability of event A given that event B has already occurred. The classic example of an inversion of the conditional, what we call people confusing this, was the O.J. Simpson trial, right? Alan Dershowitz testified that 99.9% of the men who beat their wives never end up killing them. And if you read the jury notes, jury people found that statistic impressive. It helped in not convicting him. 99% of the men who beat their wives, they never end up killing them. But that's an inversion of the conditional, right? The real statistic is of the women who were killed by the husbands, what percentage of them were beaten first? And it's almost 100%. That is the statistics. Not the probability of event A given that B, but what is the probability of event B given A? Right? And this inversion of the condition, it happens all the time. Even really good scientists in dentistry make this error all the time. And if you're looking for it, if you understand conditional probability, you can spot it immediately. You can see it. How it gets by peer review, I don't know. So the take-home message on this, I'm not saying that endodontists who screen their patients, what I'm saying is endodontists who screen their patients and don't understand conditional probability or type 1-2 errors and the relationship between sensitivity and specificity, I'm saying those doctors are going to make a lot of errors. And if you're going to screen all your patients fine, just be aware of what the danger is in that you don't end up with a lot of overtreatment. And understand the difference between a task-centered scan and a global scan, a screening. This is a task-centered scan. This endo was started in another office. They had trouble with it. I couldn't find all of the canals. I knew there were 3. I took a radiograph. Oh, I can see it here. It tells me exactly where that canal is. Now I know where to look. I'm not taking a scan and saying, let's go fish. I'm taking a scan. Let me find a specific thing that I'm looking for and let me find it. That's a task-centered scan. It's not like, hey, I just had a patient cancellation. You're here for a cleaning. Let's take a scan and see what we can find. There's a lot of danger there. Okay. Same thing here. This is a, whoops. This is a task-centered scan. I'm halfway down the route and I'm not finding it. Let's take a cone beam and see exactly where I am. I'm not fishing here. I'm looking for a specific piece of information. And I'm unlikely to make the same kind of errors that I would make if I just have a patient, you know, I got this pain on top of my head. Oh, let's take a scan and see if we can find anything that may explain it. You're going to make a lot of errors with that. Okay. How am I doing on time? Okay. I don't know if this is interesting to everybody. This is the really interesting part. This is what's interesting for me, is the cognitive and perceptual, because I love learning, and I love to understand how you learn, how people learn. And in that book that John gave me, this was one quote. There's many quotes I'm going to take out of this book, but if you just read this, research in image perception has been motivated by 2 factors. First, the realization that human factors are the major limitation on the performance of imaging system. Human factors, not the technology, human factors. And second, the appreciation of the extent of human error and variation in image interpretation. Why would there be so much variation in image interpretation? And this is a really interesting subject. It should be to anyone involved in dental imaging. It is very difficult for a human observer to maintain a constant decision criteria. Remember the criteria between sensitivity and specificity. Over a long period of time. This is why radiologists will disagree with 1 out of 5 times on a second reading. That kind of makes me nervous, right? Because of human factors. It's not a function actually of the test, it's a function of the human. So these ROC curves that we spend all this time trying to understand, and bays that can help us with understanding how the posterior test probabilities come about, doesn't tell us anything about the source of the human errors, and that's what's really interesting. So what is the nature and cause of the misinterpretation of images? And what the medical community has learned is that these are two different kinds of errors, perceptual and cognitive, both. And this is where this book is so valuable, and I thank John for, I can't thank him enough for giving me this. He gave me this, he sent me this book. I sat down and read it. I read it from cover to cover in one night. I could not put it down. My wife thought I had lost my mind. I said, God, this is unbelievable. So I hope I can just transmit a little bit of why this is so interesting. And the key fact from this, and this is going to be hard for you to really understand, what they did is they went out to all of these medical radiologists. I think it was either breast or maybe it was lung pulmonary radiologists. And they identified a certain small percentage of people who made fewer errors than anyone else. They were called experts. These are the experts. Everyone else was making all different kinds of errors, but this select group of people made far fewer errors than the other group. And they isolated this population of things, and they said, we're going to study these people and find out what it is they're doing so we can transmit this information to these other people who are making more errors. And they found a very, very discouraging fact, and that is this. I'm going to read it. The experts themselves have no conscious knowledge of what the mechanism, perceptual or cognitive, are that lead them to the decisions they make. What does that mean? That means the experts themselves didn't know what it was doing that made them experts. And once you get your head around this, it has many, many ramifications, but what it means is if you come up to me and say, tell me, you're really good at reading these things, teach me how to read them. I can't teach you how to read them. I can teach you mechanically how to manipulate the scan, but I can't teach you what it is that makes me make fewer errors than you, because I don't know what that is. I don't know what it is that I do. I just know it. And there's a cognitive reason for that, and this is what we're going to talk about. So, an expert is someone who provides consistent, reliable, and accurate diagnostic performance in the task of interpreting radiographic images. They make fewer errors, okay? The other thing that's really hard for the people in this room, especially endodontists, is that expertise is domain specific. And what does that mean? That means because you are good at reading periapical radiographs does not mean that you're good at reading cone beams. Not any more than Michael Jordan, who is the greatest basketball player that ever lived, could go on a baseball diamond and have that same level of thing. It's domain specific. And you have not looked at enough cone beams. You have to look at thousands, many tens of thousands before you develop that expertise. No one in endodontics has that expertise today. If you're going to look at this and you're going to say you know what this means, I don't think so, because you don't have enough schemas in your long-term memory to know what the reconstructions what the errors and reconstructions can look like, or even what the range of normals looks like. You think you do because you have this skill in periapical radiology, but you do not have this skill. And when I lecture to endodontists, believe me, that message doesn't go over good. They don't like to hear that. Expertise across a wide range of domains is rare. Expertise is non-transferable. That means if I am an expert, if I make fewer errors, then I can't give that information to you. Okay? They don't ask people who read mammograms to read chest x-rays. Why? You're going to understand why that is. So again, there's this whole vocabulary that professionals look at. Obviously, we don't have time to go through all of this, but this is the vocabulary that professionals use in talking about perception and cognition. So This is kind of the take-home lesson. Limiting knowledge to a specific anatomic scene facilitates tuning of specific perceptive and cognitive skills that give the expert the advantage. In other words, we have certain schema that we recognize immediately. We recognize it immediately, and that's what gives us the advantage. And I think I can make that. When I look at this, I recognize this, right? Because I'm tuned to it. I've seen this 10,000 times, more than that, probably 50,000 times. So I pick this up right away. Now, it's true that I disregarded it, but it wasn't. This is a different kind of error that we'll cover in a little bit. Those errors are divided into scanning errors, decision-making errors, and recognition errors. So this is what the medical community has learned. First of all, experts are much better than residents. Expertise is domain-specific. It doesn't transfer. Because you're good at reading PAs doesn't mean you're going to be good at cone beams. Competence requires specialized training with feedback, and this is where we're weak. So we look at 10,000 CBCTs. The problem is we don't get feedback on a lot of those. So we don't know whether we made the right call or not. We don't know. So we're weak on the feedback. The experts themselves have no conscious knowledge of the perceptual or cognitive mechanisms. And here's the big one. Studies of chest competence are instructive. So let's look at what chess can teach us, because it's got direct application. Okay. I'm going to go through this quickly. So in this book, the Expertise and Expert Performance from Cambridge University Press, if you're interested in this, it goes through a long description of what they learned from studying competence in chess. And it's really interesting and is directly applicable to this. And it explains so clearly why I cannot give you any expertise, or why an person with high expertise can transfer somehow that knowledge to a non-expert. Chess is particularly good because it's easily measured. The gold standard is really easy to see. You either win or lose. And it's actually the prototypical TED best for theories in cognition and perception. So they did a study with chess grandmasters where they took these cards with chess positions and they flashed them for 5 seconds in front of the grandmasters. And then they said, you know, here's 5 minutes. All right, now duplicate these positions on the board. It turns out, with just a quick look, the grandmasters were much, much better than even 100 people below them on the master scale. They could reproduce these positions just boom, 5 seconds, boom, and they could reproduce the positions. And that got cognitive and perception people thinking, it can't be that they're scanning and they're studying this. It has to be a global recognition of what's going on. So they do this, 5 seconds, okay, now duplicate it. Okay, now duplicate this. Now duplicate this. And then they did a very interesting experiment. They took nonsense chess positions, positions that didn't make any sense, that you'd never see in a game, and they tested the grandmasters. Do you know the grandmasters didn't do any better than the novices? Interesting, huh? Why? Because that global search of those positions, the only reason they're able to reproduce those at such a high fidelity is because they've seen those positions thousands of times. And that is stored in their long-term memory. That position is stored, so they only need to see it for 5 seconds. So this is what they learned. Much of the chess master's advantage over the novice derives from the first few seconds of thought. And I love this line. This Jose Raul Capablanca, probably the greatest chess player who ever lived. He was a Cuban. He went into this room once. I guess he did it many times. I don't know. They had 130 people, and each of them I mean, this was a huge room like this with chessboards, and he went around and he played 130 people, and he beat them all easily. And he'd just come by, and, oh yeah, okay, go to the next one and look at it, yeah, okay. And they couldn't figure out how he was able to do this. And they said to him, how do you think 6 or 7 moves ahead for 130 chess games? It's humanly impossible. He says, but I don't think 7 moves ahead. I only think 1 move ahead. But it's always the right move.